My screen is visible, sir?
Yes,
Yeah.
very clear. Thank you.
Yes. Yes, ma'am.
Yes. So good afternoon, everyone. We are here on behalf of AMPT. We are just here to share our whatever the learning we are taking from the AMPT. For that, the today topic, that is the myokinetic, according to the muscles and the fascia relation, how one region, the muscles of the like the stabilizer affect other stabilizer, or how can the stabilizer can influence the mobilizer, or how can the mobilizer to mobilizer, they can also affect each other. So for that we have the this is a made in India approach, that is the myokinetic chain for the myofascial dysfunction, in which we will cover muscle as well as the fascia, because we know the relation. Whenever we talk about the muscle and the fascia, we cannot separate them, we cannot separately treat them, because we know that the influence of muscle as a contraction or as a fascia contractile structure. So we have to treat both structures simultaneously. For that, we have to see how the chain can be influenced from one region to another region. The patient who is having a pain of the cervical spine, and after some times or before that pain, he or she was in the pain of the plantar heel pain, or she was in the pain of the knee pain, or in the shoulder pain. So this is the chain reaction which is going on because of these muscle fiber, or the full web that is known as the fascia. They can be influenced from one region to another region. So for that, we are just our last session for the Indonesia chapter, where the sir has explained about the myofascial chain, how these chain affect the working, the function and the dysfunction of our patient or as a subject. So we see that how they influence each other as a myofascial chain, because without understanding of myofascial chain or the muscle or the fascia, we cannot treat our patient who are having a myofascial pain. Either the cause is the adhesion, either the cause is the tightness, either the cause is the spasm. We have to see that why the one treating one region, the patient is getting relief on another region, or one activity is influencing the other activity. So this is the, it means there is a something, the chain is going on which influencing each other. So we can, it's like that if there are two students in the class, so they either the good student can influence the bad student, or maybe the bad student attitude can be influenced to the good student also. So it means there is a influence is going on vice versa. Either somebody can take the good one or somebody can take the bad one. It depends upon the power of that particular student or the power of that particular structure. If the muscle is strong, they will influence more the fascia, or the fascia is strong, it will influence the muscle more. So this is the way we know that the fiber, according to the fiber of muscle and the fascia. So we will go step by step to understand that what are the functional unit of the muscle, what are the role of the fascia, for better understanding of the myokinetic therapy, which is completely, I will say, based on the myofascial chains, because we know that how the chain from distal to proximal, or the muscle origin to insertion, or the fascia from head to toe can affect each other. For that, we are learning this myokinetic therapy, that is based on the myofascial chain or the myokinetic chain. So we
Okay,
know that.
sorry, Doctor. Let me explain to the audience first.
Yes, sir.
Tadi Dr. Situra Sahni menginformasikan kepada kita tentang bagaimana hubungan antara myofascial dan myokinetic. Jadi mereka saling mempengaruhi. Tadi beliau sudah menjelaskan tentang memberikan contoh student, ya, dua mahasiswa yang saling mempengaruhi satu sama lain. Ya, oke, go ahead.
Yes. So for this understanding of myofascial chain, how we can understand, because we know that the chains which are running in the frontal line, back line, superficial, deep, it means that all around these chains are working or they are influencing. So we, because we cannot isolate the operation of the muscle, we cannot operate it muscle separately. So it means we know that the muscle which are in the contraction form, so definitely the fascia which is related above the muscle, can affect. If something is in the contraction, it will affect the working of fascia also, or if it is tight, it will not allow to the muscle to do the contraction like this. So this is the way. It means that the chain reaction should be understand first, then we can go in a further line, because we know that the myofascial chain. So in this pictures also you can see that how we are seeing that how these back line of chain, how the superficial chain, the front chain or the lateral chain can affect the working of each other. If the patient is having a pain in a shoulder, it can affect the contralateral side knee also. So it means there is a chain is going on. It's a chain which is coming in the oblique form, the chain which is coming in the front line, the chain coming in the back line, the chain coming in the lateral line. They can influence each other. So it means the chain, what chain? The muscle. But muscle is also protected by in the in the covering of the fascia. So it means if the muscle is not in a working position, definitely it will affect the working of fascia also. Maybe the fascia can be tight, maybe the fascia can be another region, fascia can be tight. So we have to release that fascia so that the muscle can work easily. So this is the way it is important to understand about the myofascial chain first, then we will move towards the kinetic therapy. Yes, sir.
Oke, jadi beliau sudah menjelaskan kepada kita tentang bagaimana hubungan antara muscle dan fascia. So dari very close relation ya, Dr. Situ Sani, very close relation between muscles and fascia, bonding together. Oke, beliau sudah menyampaikan tentang konsep myofascial channel yang membantu menjelaskan tentang bagaimana tubuh, bagaimana distribusi forces from right to left, up to down, dari atas ke bawah, and dari dalam dan dari superficial. Ya, superficial. Itu sangat penting, ya, sangat penting. Oleh sebab itu sangat penting untuk mengetahui dan memvisualisasi tentang bagaimana myofascial meridian trench line. Tadi there is a picture. I love that picture you explain in the right side. Jadi otot itu tidak bekerja dalam sendiri, not operate in isolation, ya. Itu merupakan sesuatu yang sifatnya kontraktil, hal-hal yang terkait dengan kontraktil, elemen, ya, di mana meridian ini bisa menjelaskan, to explain, ya, bagaimana perkembangan development from primary central trigger point in the area of the body, dari tubuh kita untuk untuk distally, meaning from distal, ya, Dr. Sani?
Yes, sir.
Point distal meaning point from distal to proximal, or?
Yeah, distal to proximal.
Okay.
They can affect both the region. Maybe there is a central trigger point in the proximal. It can be the satellite or the secondary latent trigger point can be in the proximal or the distal part also. It means there is a chain. The one area I am having a trigger point in my upper trapezius. So maybe there is some latent trigger point in the deep muscle, that is the levator scapulae, or maybe there is the trigger point can be in another region also, maybe in the quadratus lumborum or the thoracolumbar fascia. There can be the secondary or the latent trigger point. So it means this is the chain. Because of that, one central trigger point can affecting and any other region with the secondary trigger point or the latent trigger point or the satellite trigger point. So this is the way proximal can affect the distal can affect the proximal also.
Oke, ya, jadi beliau sudah menjelaskan. Wah, very complicated, dokter. Very complicated. Not easy to. I can only explain that. Not easy to understand. So maybe during class next time you have to explain in detail about this.
For upper limb activity.
Okay.
When we do upper limb activity, distal muscle influence the proximal more.
Oh, distal influence more to proximal.
On the proximal muscle.
Okay.
For lower limb activity, It is the proximal muscle that affects the distal muscle more.
Okay. Okay,
Okay.
clear.
So both ways they can influence each other, and it is depending upon the functional demand. One muscle can try to help another muscle which is far
Okay.
away.
So it is let's say not impossible. It is a good way that they both working together, cannot stand alone. Oke. Ya, jadi teman-teman semua, jadi menurut Profesor Sentil dan beliau, bahwa ini dua hal ini sangat mempengaruhi satu sama lain dan tidak bisa berdiri sendiri. Oke, clear. Thank you. Go ahead, please.
Yes. This picture will give you a more better idea that you can see that how the myokinetic chain, how the myofascial chain is important to treat the myofascial dysfunction. So in this picture, like the sir was explaining that how the upper limb activity influence the lower limb activity, or the treatment for the upper limb, treating upper limb, we can also treat simultaneously, or the effect will be went towards the lower extremity, or the lower extremity influence the upper extremity. Like in this, the people who are doing the exercise, so they are doing some upper limb exercise, so it means, and simultaneously these lower limb activity they are doing, so it means the stability for the posture and the mobility for the other area can influence. Like if I am giving the stability to one posture, my stabilizer are working for the stability, and simultaneously other region where the mobility is going because of the mobilizer, they can influence each other. So they are maintaining the chain, the myokinetic chain, so they are influencing one to each other. It means the stabilizer can also influence the stabilizer, like the sir has already explained that deep cervical flexors, they can influence the diaphragm also, or they can influence the pelvic floor also, because they are the stabilizer. Or if I am doing, while doing the stabilizer, I am doing my stabilizer and for the endurance, or I am doing any upper limb activity, so these stabilizer can also influence the mobility of the mobilizer. So they can influence, either they can inhibit, or they can, if they are overactive, they can inhibit. If these muscles are in the weakness, they are in the tightness, so they can facilitate also, because we know if somebody is weak, we have to facilitate. If somebody is overactive, we have to inhibit them. So this is the main basic of myokinetic, where one activity is influencing other activity. Stabilizer influence the mobilizer. If they are weak, they will facilitate. If they are overactive, they will inhibit. So this is the way the chain reaction of myokinetic work on each other: stabilizer to mobilizer, mobilizer to mobilizer, or stabilizer to stabilizer. Yes, sir.
Okay. Now I understand. I understand. Let me explain to others. Jadi menurut beliau ini bahwa myofascial chain, myokinetic chain itu sangat penting karena movement dan stabilizer itu saling mempengaruhi, influence each other. Ya, I say influence each other. Jadi keduanya. Jadi kalau kita lihat, if I see the picture you provide, now I clearly understand what you explain. Yeah, what I explain. So basically, movement, stabilizer, and what's another one? Stabilizer and mobilizer itu bekerja saling membantu dan saling inhibit and facilitate.
Yes.
Can inhibit, can facilitate. If hyper, then inhibit. If lower, then will facilitate.
Yes, correct.
Is that, okay. Jadi ini now I understand bahwa antara mobilizer dan stabilizer ada dua hal yang entity yang saling mempengaruhi satu sama lain. Kalau misalnya yang satu lemah akan memfasilitasi, dan kalau misalnya yang satu terlalu over itu akan diinhibit atau dikurangi intensitasnya. Yes, go ahead.
Okay. And this is the basic of muscles, why what is the meaning that how the muscle fibers, which are, we know that they work according to that their origin and the insertion, from where the muscle is attached or where they are going to insert. So this is the main characteristic of the muscle. They work on as a contractile fiber. They work as a origin and the insertion. And we know that there is a unit, that is the sarcomere, in which that shortening of the lengthening while doing the stretching and in the relaxation position, this time these fiber works. That's why we say that muscles are the contractile structure, because the protein from which they are made, that is the myosin, that is the thickened part, and the actin, that is a thin part. So when there is a stretching is going on, so how the myosin is going in the stretching, so it means that a lengthening is taken by the sarcomere, that is the basic unit of that muscles. So that time these take the lengthen, and when the muscle relax, they are coming back. So it means the main protein for the contractile structure that works on the contraction time, and after that sometimes they are coming back, because muscle is like, this is like elastic structure. This is a contraction is going on, so we can easily understand. So this time, suppose this is the thickened part myosin, and this is the thin part, that is the actin. So this is the myosin, this is going on the, when we are lengthen, we are doing the some stretching that time, and this is the shortened position, this is the lengthening position. So this is the contractile structure. If the patient is having a myofascial pain, that time the muscle is in the tightness, they are not working. That's why we do that. We give some techniques according to muscle energy technique, or the myofascial release, or the fasciomuscular release. There we try to release the muscle which are stuck because of the tight fascia. So we give them a contraction so that they can easily release that their adhesion between muscle and the fascia. So there are some basic units that work on that sarcomere, and because of the protein fiber, that is that myosin and the actin, they are the main which responsible for the length by taking the contraction for the lengthening or coming back. So we can say that muscle can add or subtract sarcomere through their longer term adaptation. When we are going the contraction, giving in the lengthening position, that time these fiber works. So this is about the muscle. So we can understand that why the muscle coming, not only the muscle is coming in the shortening position, that time these units, that sarcomeres or the entire muscle, because of the lengthening of the sarcomere, they are getting the length. Yes, sir.
Ya, jadi ada Jadi ada dua hal yang sangat penting yang beliau sampaikan.
You can explain by this picture. You can understand by this picture.
I will explain.
Easily you can yes, sir.
I can see the picture. I can explain from the. So the main idea here is about sarcomere. Sarcomere itu karena otot itu ada dua hal ya, kontraktil dan elasticity. Ya, tadi beliau sudah menyampaikan kalau kita lihat di gambar itu, jadi kontraksi dan elasticity itu sangat penting, terutama kontraktil komponen itu sangat penting dalam sistem myofascial. Karena tadi sarkom itu beliau sudah menjelaskan yang bisa kontraktil dan bisa elastis, ya. Dan itu sarkomer ini bisa memanjang, dalam pengertian pendek bisa memanjang dan memendek. Ada satu saya lihat di slide bahwa muscle stretch effect generally takes somewhere around 20 to 30 seconds to achieve. Is that right, Dr. Situ?
Yes, perfect.
Okay. Yeah, that's right. 20 to 30 seconds. And then, however, muscle can add or subtract sarcomere through a longer term adaptation process, thus changing the actual length of the muscle. So makes sense. Now we can understand now by seeing this picture, and especially your explanation, even me, I can understand clearly. Yeah. So yeah, after this we will read again. Thank you. Go ahead, Dr. Ritu.
And now this is what we talk about the muscle. They are the contractile structure. They need the kinetic, the active energy force, because we know that the kinetic and the kinematic, where we work on the kinetic, that is the active force of the muscle. But when we talk about the fascia, that is the fascia has, like muscle has a origin or insertion, but the fascia has no origin, no insertion. This is a continuous structure of web, like that spider web you can see in this picture. This is the spider web, that our full body is covered with the web like structure, like the blanket structure, that is known as the fascia. So it means if we are pulling from one region, so it can, we can pull it from another region also. So it can be like a tug war like structure is that. So when we tug on or a bend fascia anywhere in the body, the tug spider web throughout the system, so it will affect the other also. Because of that, the structure, the fascia structure, because this is a full web, we have to treat both the, because one is a contractile structure, and in this fascia we have to see that, because there is no any specific point from where it is coming or where it is inserting. So we have to check the whole as a whole covering of our body. And we
Okay.
know that in our body, what all the structures like muscle, ligament, nerves, blood vessels, arteries, capillaries, everything is covered by the one covering that is known as the fascia. So it means the fascia distributes strain in all directions. So we cannot say that we will only treat the muscle. We have to see that what is the covering of that particular muscle that should be treated together. Like if I am giving somebody a gift, but I am not giving wrapping on the wrapping sheet, so it will not look tidy, or it will not look beautiful. But as I will cover my gift into the wrapping sheet, then nobody knows that what is inside, but I know that what is inside. So it will look pretty, that yes, I am presenting in a right way, in a good manner. The same thing, that all the structures, they are, if we will remove the fascia, so it will look like a skeleton only. So fascia is the covering of our body. Like for outer covering, we are wearing the clothes. The same that our body, the full body system, the full skeleton system is covered by the fascia. Like if I am pulling my t-shirt from this side, so definitely it will affect from the lower side also, because I am pulling it here. So same, like if I will pull the fascia from one side, it will affect the other also. Or we can say that all the muscles are packed in the facial covering. All the ligaments, they are covered with the fascia. All the tendons, they are covered with the fascia. So this is the way we think that fascia is the full covering of all the structure of our body. Yes, sir.
Okay, now I understand. Now, when you explain this, I remember, because what is called pericol here, sometime at night, I remember my blanket. If I pull in one side and then I pick other side,
Exactly.
totally the same. Okay, jadi makes sense, really makes sense what Dr. Ritu explained to us about fascia. So fascia, there's no religion, not origin of this fascia. There is also insertion. This is a continuous structure, and then it is also without interruption. So kalau kita bayangkan aja kita menggunakan blanket ya, blanket atau pakaian menutupi tubuh kita, kalau kita menarik di satu bagian tertentu akan mempengaruhi bagian yang lain. Nah, itulah fascia. Ya, like spider, totally like spider web. Spider web, I can imagine when I was a child, if I touch the spider web, I pull it from this side and affect in the other sides. So yeah, so apa yang paling penting bahwa fascia itu distribute in strain in all direction. So if we treat something what is called muscle, we have to a comprehensive treat, not only one, because this concept of fascia. Just remember about the web of the what is called web of the spider, yeah. So affect each other. So we cannot trade. Kita nggak bisa treat only one part because they affect each other. Yes, Dr. Ritu, am I right?
Yeah, perfect,
Yeah.
sir.
Okay. Yes. Go ahead. Clear. Yes.
So we know that like the muscle, we see that they are made of actin and the myosin protein, which works when the contraction is going on. The same in the fascia, we see that the fascia is also, they are contractile structure and they are made up of elastin and the collagen are the primary proteins that make up the fascia. Like there, the actin and myosin in the muscle, in the fascia component, there is the elastin and the collagen. Elastin is like a rubber band. It is an elastic, stretchy protein that is able to stretch and the snap to right back. It means it will stretch, take the stretchy, but it will come back at their place. So it is a rubber band like structure. And the collagen, it is like a steel cable wire like structure. That is the collagen. It has a high tensile strength, because we know that if there is a full covering on my body, but if there is nothing, no tensile force will be there, so these, but our body will be in just like a overlap on each other, like all the organs which they will overlap. So it means there are some covering of the fascia which is covered all the structure, are like in the visceral also there are a fascia which is protecting all these organs by giving the tensile force so that they can keep on their place. If there is no fascia, no collagen fibers like a steel cable, no tensile forces giving, only the compression forces coming, so all the structure will be overlapped with the each other. So it means the fascia component, the one is the elastin, which is taking the coming back capacity is there like a rubber, or the collagen, but that is a like a steel cable. They will make the tensile force with the each other. They make structure so that other structure can keep on their places. They will not collapse on each other or overlap on each other. Yes, sir.
Okay. Yeah. Yes. Now, I hope that our friend here understand, because it seems like complicated, but if we pay attention carefully and then we understand, especially Dr. itu mention about actin and myosin. Jadi menurut beliau itu bahwa di fascia itu ada dua hal yang terkait, ya, protein, yaitu elastin dan kolagen. Ya, elastin dan kolagen ini juga bersama-sama dengan proteoglikan dan satu lagi fibroblasts. Nah, fibroblasts ini menghasilkan kolagen dan elastin. Ya, beliau menjelaskan elastin is just like what is called karet, rubber, ya, yes. Karet. Sementara kolagen seperti apa? Kabel steel kabel, ya. Yeah, kabel steel, yes.
Like this in picture you can see that these are
yes, I see. Yeah.
They are maintaining the force.
Which one there is collagen? The big one? Oh yeah, the black one.
They are maintaining the force so that the other structure on which they are covering, they will give the stability. They will not try to the liver or the lungs. They will not overlap on each other because of these tensile forces. Because of this collagen fibers of the fascia, they are maintaining so that they cannot overlap on each other. So they are maintained on their places.
And elastin just move, change, easy to move, easy to change. Okay, so collagen is more than elastin in fascia or equal?
Both are working together.
Okay,
like
together. Okay, so
one is giving the compression force, one is maintaining the tensile force.
That's right.
So
that's compression and maintaining.
That we will explain in further slides. If one is more and another is high, what will be happen to the dysfunction, that I will explain.
I believe that they are familiar with this concept, Dr.
Yes.
Ritu. So okay, go ahead.
Professor Asad.
Yes.
You can simplify by telling that fascia has more collagen than elastin.
More collagen than elastin.
Muscles have more elastin compared to the collagen.
Okay. So fascia more collagen compared to elastin. Muscles, otot itu lebih banyak elastin than collagen.
Yes,
because collagen can move like rubber. while elastin, like rubber, and collagen like iron cable, right?
Yes. Collagen is for strength and elastin is for elasticity. Flexibility.
Oh, yeah. Because elasticity because can move like rubber.
Yes.
Okay. Collagen cannot move like rubber easily. Okay. Go ahead. Now we understand.
Yeah. So the fascia is work as a sensory organ also, because it is the covering. So it means whatever the sensory input we will get first, we will get through the fascia, the skin that is covered on the skin also. So fascia is the largest sensory organ in the body, and it contains 6 times the number of sensory nerve compared with the muscle tissue. Fascia contains 4 types of sensory nerve endings. In this picture, you can see that they are the Golgi organs, Ruffini receptor, Cassini corpuscles, and the interstitial receptors. So these are the sensory nerve endings can be called the fascia mechanoreceptors. So they will get the sensation first, meaning that they respond to the mechanical tension or the pressure. Whatever the mechanical pressure or the tension we get on the skin, they send the information to the brain as a sensory organ. So in this also, we have a 4 receptors, mechanical stimulation receptor, that is seen, you can see it here also by their name or by their presence on the skin, that you can also see that where they are present. So they get the mechanoreceptor with the mechanical pressure or the tension. So the fascia is also working as a sensory receptor.
Okay, but mostly in the dermis, in the dermis part, in the dermis area.
Yes.
Okay. No, let me explain. This is really important. Menurut dokter itu, jadi fascia itu merupakan sensori yang paling besar, the largest in our body. So fascia the largest sensory in our body, yang terdiri dari ada 6 sensori, 6 sensory nerve yang bisa kita bandingkan dengan jaringan otot, Ada 4 types of sensory nerves ending, yang bertanggung jawab, yang responsif, bertanggung jawab pada stimulasi mekanikal. If we see, I see the picture for Golgi organ, Ruffini receptor, Pacini corpusculus, and interstitial receptor. Keempatnya ini sangat penting yang terkait dengan fascia ini, karena keempatnya ini bertanggung jawab pada stimulasi mekanikal atau mechanical stimulation, dan keempatnya ini Golgi organ, Ruffini receptor, Pacini corpusculus, correct me, and then interstitial receptor itu disebut dengan mechanoreceptor, yang berarti bahwa memberikan respon pada mechanical tension dan pada tekanan. Jadi ada 4 yang paling penting. Kemudian fascia is the largest sensory di sepanjang tubuh kita. Tadi saya sudah tanyakan bahwa umumnya mereka itu ada di bagian dermis. Yes, go ahead, Dr. Ritu.
Yes, sir. And also fascia work as the proprioceptor also. Like first we saw that fascia, it is the covering, then the sensory as a sensory organ, and the fascia has been shown to play a strong role in the proprioception also. Like that the process of any conscious and the subconscious sensing of joint position and motion and the posture, that time also the fascia, it control the vital motor control or the ability to control the body movement in our conscious and subconscious, both the position. So it means that if I am sleeping, just like I am sleeping, somebody has put their hand on or somebody has hit me. If I am in the sleeping position, definitely I will, if I am not opening my eyes, but my body will affect I will keep their hand away from my body, or whatever the reflex action will come, like the proprioception will definitely come through because of the fascia, because fascia is also working as a proprioceptor. So it gets the proprioception, and after that our body gives the reflex level. Like something is hit on my knee, so the reflex action will automatically that I will take away my knee from that jerk also, or whatever. If there is a something is burning, sense burning, that some fire is there, so I will quick take the reflex action right by keeping away my hand. So it means that is the proprioceptors are also working with in the fascias. Because of that, we say that fascia is also work as a proprioceptor. So this is the way, like sensory organs, we feel the touch, we feel the tight hold of the person. So that time also that sensory receptors work. We know that we can feel that the soft touch or the hard touch, or if there is something is hitting, so how the reflex is coming, that is also as a proprioceptor. So we can say that fascia can be a sensory organ as a or the proprioceptor also. Yes, sir.
Okay, okay. Now I know. Sometimes if someone put what is called, they don't
And
suddenly the cigarette, for example,
yeah.
cigarette, and then suddenly we get the reflex. This is
Hmm.
because it is called proprioception, because
Yes.
fascia juga itu merupakan apa namanya ya, merupakan proprioceptor di tubuh kita, ya.
Yeah. Yes.
Ya, tadi beliau sudah menjelaskan kalau misalnya di tubuh kita ada tiba-tiba kita we are sleeping and then somebody tap in our body and then kita tiba-tiba akan melakukan gerakan refleks. Karena proses proprioception ini, ini yang dilakukan oleh fascia. Fascia fungsinya salah satunya adalah proprioceptor dalam tubuh kita, ya, pada tubuh kita, ya, muscle receptor. From there is a new research that we cannot separate muscle receptor from joint receptor due to the way fascia transmit person. Yes. Makes sense. Seems like I agree with this based on your explanation, Dr. Ritu. Okay, go ahead.
Okay. So we see that how the fascia and how the muscle fibers, they work together because of their collagen fiber, their elasticity, or their protein bonding with each other, with the actin and myosin, the muscle, and the collagen and the facial fiber. So these are the things that fascia is an uninterrupted three-dimensional web of dense connective tissue. Means that fascia is in that, we can say that they are a complete connective tissue web, where they take the forces for the compression also, or they maintain the tensile force also. So it means there is a 3D like structure in the fascia, that they can be a connective tissue system, and that permeates the human body, forming a whole body continuous with their structures. It means they are covered whole body, and if there is something is disturbance in the muscle fiber, they are not able to do so, it will affect the outer, the facial structure also, because the muscles are enveloped with the fascia. So it is a fully packed structure of all the structures which are packed with the fascia. So it is a web like structure. It is very
Okay.
easy to see by
Yeah,
seeing
yeah.
this picture. You can see that all the structures like the muscles, like the tendons, like the skin, they all are covered with the fascia, which is also a connective tissues made with the connective tissue. So we can see in this picture also, there is a very easy to understand that all these structure like the epidermis, dermis, superficial fascia band, subcutaneous fat, then deep fascia, and then the muscle. So it means after these covering, the muscle is coming. So it means if there is some tightness or adhesion and the lengthening or the shortening because of in the fascia, it will affect the working of the muscle, because it is covered with muscle, which is superficial fascia, deep fascia, after that the skin, then fascia, then the muscle. So you can easily understand that they can influence each other by their placement itself. Yes, sir.
Dari kulit, skin, fascia, and the muscle. Dari kulit, kemudian fascia, dan muscle atau otot. Dan ada tiga dimensi daripada fascia ini yang merupakan. So these 3 dimension walking together very closely, bond each other.
Yes.
Yes. Go ahead. I think easy to understand. Go ahead, Dr. Rito. Yes.
And this also in this picture, by this picture itself, you can understand that this is an article on the reduced thoracolumbar fascia shear strain in the human chronic low back pain. So this is in this picture, no low back pain, but this is the picture of that with the low back pain. Here you can see that the how the fascia fibers is distributed, and in this also. So it means that when the patient is having a specific pain, so these fibers are not in the proper working, because there are some fluids which gives the gliding to the muscles. This is known as the hyaluronic acid, which gives the fascia. It provides an extracellular matrix, that is the gliding lubricant. This will give the lubrication for the covering the muscle, so that the free contraction of the muscle is going to happen. So if there is something fascia related, the patient is having a pain, the fascia is tight on that area, it means it will not allow the muscle, because it is not producing that acid, that component which is providing the gliding to the fascia. So the muscle will not be easily glide. So you can understand by this picture itself, you can see that it's
We
the
can see.
component of, like in our articular cartilage or in the skin, this acid is present, that is giving the gliding for the muscle. So this is producing by the fascia. So if the fascia is tight, it will not producing the layer of hyaluronic acid which is in between the fascia and the muscle. So the muscle gliding will be very tight. So the fascia will be in the tightened position. So the patient will say that I am having a low back pain. So when I am doing upper limb activity, I am getting this pain. I am feeling the catch there because of the tightness of the fascia, because fascia is not allowing the muscle to do the contact. Yes.
Yes. And I just want to say one thing, Dr. Rito, that you really good teacher. You really good teacher. Yeah, we can clearly understand what you say, especially from this ini ada hasil penelitian. This is a research I see that it is published in a journal. Itu kalau kita lihat ada yang dengan low back pain dan ada yang tidak dengan low pain, itu kaitannya dengan what is hyaluronic acid between fascia and muscle. You highlighted it, you bold this, it's really important. And then so this means that fascia provide an extracellular matrix that is that is leading lubricant upper muscles. So sliding or sliding between tissue and organs that we can see, like this, what is called sliding. We know that sliding. So we can see in the picture with low back pain and without low back pain. Yes. Go ahead, doctor. Very nice. Go ahead.
And this is also because of that why it is important to treat the patient. We cannot only say that we will treat the muscle only. We have to treat the fascia equally, because the fascia gives the posture support for the structure. It transmitting and dispersing the forces from one region to another region. The tissue permeability and extensibility that it gives because of these extracellular matrix fluids, it gives the movement to the muscle in between the fascia and muscle, and the proprioceptive as well as the sensory organ also. It means that we have to treat both the structure together, and training for fascia is also important, because if there is a tightness in the my arm, if there is a tightness of the fascia, it is restricted the glide. So what I will see, that I will check that either the proximal glide is restricted or the distal is restricted. So it will not allow my movement of flexion and extension of the hand. But if I will release the fascia, according to the restriction, where it is restricted either in the for the extension or the flexion, which side of fascia is restricted, I will give the glide, I will release the fascia, so it will allow the movement of my that particular structure. For the hand or for the neck, if I will glide the fascia for the neck, if my neck movement is restricted, so I will release the fascia, then it will allow the muscle for the movement. Yes, sir.
Okay. Ya. So, Dr. Ritu mention clearly, menjelaskan bahwa treatment antara fascia dan otot, ya, because to my understanding, personal understanding, that if we treat, let's say some of our part of body, we just focus on the muscle. Sometimes we forget about the fascia.
Yes.
And now Dr. Ritu explain to us, dia menjelaskan kepada kita bahwa treatment untuk fascia dan otot atau muscle itu harus seimbang sama-sama, bersama-sama, together. Yeah, so I agree with you that there are some consideration where fascia training is important. Related to us training muscles. Not only one, because mostly, now, especially in Indonesia, to my personal understanding, that training mostly related to muscle.
Yes.
Forget about fascia. But it must be equally treated, right? Okay.
Yes.
Go ahead, Dr. Ritu. Go ahead.
So it is important to understand that we have to treat both the structure together, because we know that the bone, the muscles, the nerves, all are covered with the fascia. So it means the treatment related to the fascia, like in our AOMPT, we are having the course fasciomuscular release. Like people do the myofascial release, but we do the fasciomuscular release, where we can activate the muscle, then we can glide the fascia, or first we can glide the fascia, then we activate the muscle. So it means we will do both the things, but with the active participation of the muscle, then we will glide the fascia. So it is important to understand the role of fascia for understanding the myokinetic, because what myokinetic, one structure influencing to other structure, one region influence to another region. So it means the structure which is covered with the fascia, how we can forget that structure, and only we are focusing on one structure.
Yes. This is another mistakes happen. Mostly, if we, sorry to say, based on my experience, what I have seen in Indonesia, if we treat about one part and forget another part, just one part, and then most importantly, only treat muscle, forget about fascia. Yes, this is so. Correct. This is really important. This is important, especially we need to conduct a special training about this, Dr. Ritu and Professor Sentil, so we understand. Yes. Go ahead, Doctor. Very excellent.
Yeah. So all these structures, when we talk about, like all these structures, like the nerves, like the capillaries, and like the collagen role, these all structures are in the tubular form. So it means they make that, like the nerves, they are the unicellular tubes, capillaries are multicellular tubes, and the tubes of the collagen fibers, that is woven with the fibroblast. This is the basic unit of the fascia. So we cannot say that we will treat only one part. We have to see that our body is covered with all these structure, with the nerves, with the capillaries, and with the collagen roll, that is because of the facial fiber. So this is the way we can easily, by seeing by these pictures, we can easily understand the neural net, the fluid net, that is with the capillaries, and the fibrous net, that is made up with the fascia. So this is the beauty of our body, that all these structures are working together. So treat them together and understand their logic, that how you are reaching towards that structure. Yes, sir.
Oke, jadi Dr. Ritu sudah menyampaikan kepada kita bahwa untuk treatment ini harus benar-benar ada tiga, karena ada tiga hal yang paling penting ya, yang kita mesti ini. Jadi must be comprehensive training. let's say, because of this holistic network. Yeah, I see this in the picture that there's
Yeah.
the neutral net, fluid
Yes.
net, and
This is, yes.
sorry, fibrous net are really important. Sorry, Mr. Prof Imam Waluyo, Prof Imam
Ya.
Waluyo.
Ya.
Bisa dilanjut Pak, saya mau ini sudah azan di masjid.
Okay. Okay. So
Ya,
we have half time, half hour again, because Dr. Vita will offer the topic, the next topic. So is it possible to do faster, please?
Dr. Ritu and Professor Sentil.
Yeah.
I
What we
apologize, Professor. I apologize, Dr. Ritu,
We
because
have
this
5
is,
minutes here.
yeah, I have
Okay,
to leave
okay.
you. I have to leave you because prior time here. Prior time I have to.
Yeah.
Okay.
Yeah. So it is in Dubai prior time now. I see Adan.
Okay.
Okay. So sorry about that. So I will leave you
Okay,
for a moment, and after that I will come back, inshallah. Okay,
Okay,
Prof
thank
Imam,
you,
please
Pak
continue.
Arsad. Thank you, Pak Arsad.
Thank you. Yeah. Thank you.
Now
Thank you.
you can continue, Professor Sentil and Dr. Ritu Sahni. Please continue with your lecture information. Please do it.
And Professor Imam, I want to ask you, how many minutes can we take?
Sorry, I will check my 10 minutes.
Okay, 10 more minutes. Okay.
Yes.
So we will go directly to the content of myokinetics,
Yes, sir.
and then we can have a final summary and interaction.
Yes, sir. Correct.
Yes. Okay, ma'am.
So I will take out that slides which is completely related to myokinetic. We are moving towards that. Yes, sir. Fine.
Okay. Where is your
So
PPT?
yeah. In this also, we will talk about now myokinetic therapy. That is very, very important, by which for that we were making the platform to understand about that what is the relation between the muscle and fascia. In this also, in the myokinetic therapy itself, we know that we can incorporate this myokinetic therapy with the positional release, with the reciprocal inhibition, with the post isometric relaxation, muscle energy technique, motor control retraining, and with the myofascial and the fasciomuscular, as indicated for the specific myofascial dysfunction along the kinetic chain that is directed by the clinical presentation. That is very, very important. So in this myokinetic chain, how we as a AMPT members, we are learning from sir, that I will show you with the some screenshot which I have taken from our course, that can give you a better idea that what is the myokinetic and how we are going to utilize it according to the muscles, the myofascial dysfunction. So what is already that sir has explained that what is the myokinetic therapy, that myo means the muscle, kinetic means the muscle activity, chain means influence on the each other. When one muscle activity improve the flexibility of the other muscle activity, that is called the myokinetic therapy. Like example, we can easily understand that activation of the pelvic floor muscle improve the, if the patient is not able to do their dorsiflexion and the plantar flexion, that time we instruct the patient to do the training for the pelvic floor contraction. That time they do the contraction of the pelvic floor. After that, we see, not this is not only for the writing, we have checked on our patient, we have seen that yes, it is improving. So when we contract our pelvic floor, you can check it at yourself also by self demo, that when we contract the pelvic floor, after that the dorsiflexion or the plantar flexion activity is improving. So it means that one activity is influencing, one activity is improving the other activity. So in both the condition, activity of both the muscles improving, the flexibility and influencing the each other. So in one muscle, there is a adhesion which we release that improve the activity of the other muscle, that is the myokinetic chain. Because I have influenced one, the other is automatically in the correction. So it means there is a chain that has influencing to another. So this is the myokinetic chain therapy which we are applying on our patient, and we are getting the best result. This you can see it like this is the anterior pelvic tilt and the posterior pelvic tilt. But when we are going to, we see that the muscle activity here is the core muscles that are also taking the part. So if we will correct one part, it will correct automatically the another also. It means that the stability of one muscle, like if we are working on the multifidus, so we are giving the training or the motor control with the pressure biofeedback, we are training the patient. So we see that if there is a lordosis is changing itself, can be influence the activity of the pelvic floor also. So it means that when we are training for the multifidus, the patient, the pelvic floor, the tilting itself can be changed. So this is the way one activity is influencing to the another activity. Or in this also, one weak muscle, that one muscle is the weak and one is the tight. And like in this also, the tight hip flexors and the weak gluteal. So what is the way that how we can, the muscle which is in the overactivity will we have to facilitate them, or the muscle which is in the overactivity underactivity, we have to also check that muscle, like in the strengthened or weakened muscle or the overactive muscle. So we see that, and after that we decide that how we will give the treatment to influence one activity to the another activity. You can see in this picture also which is the weak, which is the tight, how we can affect on each other. In this picture,
Okay.
this is the picture of our course, which you can see that which I was talking about, that contraction of the pelvic floor is influencing the patient dorsiflexion and the plantar flexion. If the patient, the dorsiflexion is restricted, we train the patient to do the pelvic floor contraction, gluteal muscle contraction. Then we check that either the dorsiflexion is improving or not. So this is the way this myokinetic therapy work with each other. So you can utilize on your patient also, or if you want to upgrade yourself, you can take the courses from the AMPT. The myokinetic certification course itself will give you the idea how the stability for the stabilizer or mobility for the mobilizer can influence each other. So this is the way
Okay.
in myokinetic therapy we work.
Okay. So I will try to explain to the others with Indonesian. Intinya bahwa beliau mengatakan bahwa kita sering kurang memperhatikan keterkaitan antara satu otot dengan otot lain, khususnya otot yang stabilizer, kemudian yang movement, dan juga fascia. Kurang memperhatikan. Di sini dia ngasih contoh bagaimana dorsifleksi daripada ankle bisa mempengaruhi otot-otot yang ada di pelvic floor. Ini yang digambarkan di sini, dan banyak ceritanya tadi terkaitan bahwa interaksi antara fascia, otot prime mover, movement, mobilizer, dan stabilizer itu sangat perlu diperhatikan dalam kinematik terapi ini. Nah, selanjutnya this time is the end. So before we close the session, we start with the questionnaire, because you can see there are there's one question, so you can see. I will try to read. Interesting the material so far from Muhammad Hamzah, Sumatera, Aceh. For practitioners have focused on the muscle, not concerned with the fascia, even though the most common cause of the problem is this fascia structure. The question, why do both of them have to be repaired? In fact, there are no muscle problem. Why not just fix the fascia and how? The second, can we increase or decrease hyaluronic acid with a composition of 30 kilogram per 5 gram? Why is it that? Okay, this the question is answers.
Yeah, I would request Ritu ma'am to just show the slides, the closing slides, and
Yes,
then
sir.
conclude the presentation.
Yes, sir.
Then we go on with the, because you just rush through the slides, just show the final and close
Yes,
the
sir.
presentation. Yes, ma'am.
Sir. Yes, sir. So this is all. I will taking you through the fast forward way that how we are using this myokinetic therapy to improving the patient one activity to improve the other activity. And this also that how the diaphragm, which is our stabilizer muscle, can influence even our upper extremity gripping activity also with the inhalation and exhalation. So treating or for giving the stimulation to the diaphragm by giving the exercise of inhalation and exhalation can influence the other activity of the upper limb activity, or like the grasping or with for the elevation of the hand in the shoulder patient. When the patient is having a frozen shoulder or impingement, then treating the diaphragm can also influence this elevation of hand, flexion, extension of hand also. And this is the activity of upper limb activation with the diaphragm, inhalation and exhalation. So it means the activation of diaphragm is very important when the patient is having a upper limb or activity related problem. So we have to treat the diaphragm as a stabilizer. They will also influence the mobilizer, which are known for the activity. And this is the bilateral SLR. We can check the patient is having the sternal angle that can also be influenced either in the increasing way or in the decreasing way, the shorter position according to the anterior and posterior tilt. And this is also the movement of the rotation of the body can also influence with the lesser angle of the and the greater angle of the sternal angle in the external and internal oblique, which are also known for the rotation of our body. So in this also we can influence with the rotation, and then we can check the diaphragm, the sternal angle, either it is increasing or decreasing. And this is also that when the patient after the COVID, the patient is suffering with the obstructive and the restrictive pattern, the dysfunction related to their obstruction and restrictive, then also how we keep their position itself to give them a relief, that is the positional release technique for the patient who is having a breathing pattern dysfunction. So we have to check their position while sitting also, we can treat them. And this is the activation of one muscle, like by activating the one muscle, the stabilizer, we can influence the mobilizer muscle that is in the tightness. So we can inhibit or facilitate that muscle also. And this is also the myokinetic therapy we utilize from cranial to sacrum, how we treat it, like with the cranium to sacrum, we give that, like treating the cranium, the patient getting relief in their sacral dysfunction, or treating the sacrum, it can also influence the cranium function. So this is also known as the myokinetic therapy. And if the patient is having a balance problem, so that is also the problem is in the ear, the vestibular system, and the balance is going to disturb. So there also we work as a myokinetic, where we train for the balance or we train the vestibular system. So it can also influence their balance. So it is also we can as a myokinetic therapy we see, because one activity is influencing the other activity. And this is also release of one muscle from one area when the muscle one area is the tight and another muscle is in the lengthening position. So how we can treat them at one activity, so that will also influence. If I will correct the posture, automatically the posterior or anterior tilt will be corrected. So it means they can also be a tight hamstring can lead to the lower back pain also. So we have to release the hamstring, we will see that the patient is getting relief in their lower back. That is also as a myokinetic chain we treat our patient. And so this is the chain that how one region affect the other region, like showing that how the movement is coming in the trunk rotation also and in the lower limb also. Like in starting the sir was explaining that how the force is taking by one activity to the another activity. So these are all references which we took from the different authors to understand about the myokinetic chain therapy. And so thank you so much, everyone. So it means that myokinetic chain therapy is, don't be confused that you are going to treat the muscle only or you are going to treat the fascia also. Treat the patient problem. Don't treat that whatever the structures are always here. But we have to see that what is the problem in the functional activity of the patient. After that, our evaluation, history taking, then we plan our treatment, that how we can give the release if the myofascial dysfunction, how we can treat, if there is articular dysfunction, how we can treat. For that, we are having everything is available in our mind or in our hand, so that judicially we can utilize our brain and hand for the betterment of our patient. So this is all about the AMPT always work on the patient-centered approach, and this is the myokinetic therapy approach that is also very, very useful for understanding of all the clinician, because we know that when patients say that I am having a neck pain, there is something, any history related or any cause which is in their mind. When we take the history, then they tell, yes, I was 2 years or 2 months back, I have any visceral problem, any surgery was went through, or any problem related to the heel pain or their knee pain. So that means that one activity can change the another activity, when treatment can influence the other area. So that is the myokinetic. So thank you so much for everyone to understand about this myokinetic, because muscle activity influencing each other, that is the myokinetic. One activity influencing the other activity is the myokinetic. So thank you so much. Yes, sir. Thank you,
Okay,
sir.
thank you. Thank you, Professor Sentil and Risun, Dr. Risun, Ritu Sahni, yes. So, thank you very much, and a nice, attractive lecture, and it is important for us as a basic for continue the knowledge of manual manipulative and practice in the future. So today is a final presentation from Professor Sentil and Ritu Sahni, and thank you once again, and I hope we back to the other topic. Please, Dr. Rizky, please come back to you.